Hello everyone, I'm Tom Davis, Global Sector Lead for Health and Nutrition for World Vision International and the original developer of the barrier analysis methodology. I want to welcome you to this workshop. I think you'll learn many useful social and behavior change skills as part of it that you can apply across sectors and ministries. First, since many of you in World Vision at least are taking this course in order to learn how to apply barrier analysis for use with COVID-19 vaccine acceptance, let me explain World Vision's strategic intent in that area. Our strategic intent is to use our global reach and grassroots connections to encourage vaccine acceptance and uptake by the world's most vulnerable communities to save lives, protect livelihoods, and safeguard families and children from impoverishment and violence. I encourage you to take a look at World Vision's COVID-19 vaccine response capacity statement in order to have more details on what we plan to do with vaccines, and ensure your staff have access to this document as well. This was produced back in February, but when we were looking at the vaccine acceptance in several different countries in which World Vision works and some of our other collaborators work, you'll note that it varied from 41% acceptance in India or 40% in Kenya all the way up to 81% in Bangladesh. So we have a long way to go to encourage this acceptance. This graphic shows which countries have received vaccines, at least in March of 2021, and countries that have begun vaccinations. It is starting to roll out in Africa and in other continents. And for that reason, we really need to be doing this sort of work now so that we better understand these drivers of vaccine acceptance so that we can get our messaging in place and activities in place so people are ready for the vaccines when they're available. I also want to mention we do have guidance in World Vision called Promoting COVID-19 Vaccines through World Vision Field Offices, step-by-step programmatic guidance. The purpose of that is so that you can understand World Vision's best opportunities for national COVID-19 vaccine rollout support. You can prioritize engagements, interventions, and advocacy. You can apply best practice to this support. And the guidance recommends that all field offices conduct at least one barrier analysis in their country. We have a link to that at the end of this presentation. Note that barrier analysis is not new to World Vision. We've used it in more than 40 countries just for WASH. These are the countries using the Designing for Behavior Change framework, which the Designing for Behavior Change training includes the barrier analysis training, of course. This was from a 2016 desk review of that by John Collette. So, what is barrier analysis? Well, barrier analysis is a rapid assessment, a formative research tool to identify behavioral determinants associated with a particular behavior like mask use, vaccine acceptance, child protection behaviors, so that one can develop more effective behavior change messages and activities. It's based on the health belief model and the theory of reasoned action. And one key feature is that those doing a behavior, the doers or acceptors in the case of vaccines, are compared with those who are not, or the non-doers or non-acceptors, so the most important behavioral determinants can be identified. Barrier analysis has now been used in about 40% of lower and middle income countries, and analysis is done with a simple spreadsheet. We used it extensively during the Ebola outbreak, and World Vision is studying vaccine acceptance, comparing people that plan to get a COVID-19 vaccine with those who are vaccine hesitant in more than 6 countries. These are the main determinants that are explored in these studies. Things like perceived social norms, whether you think that people important to you approve of the behavior, but also perceived severity, whether you think that COVID-19 is a dangerous disease or not. You'll learn about each of these determinants in detail during this workshop. The main steps in barrier analysis are quite straightforward. First, a standard barrier analysis questionnaire, including both open-ended and closed-ended questions is used. This has already been developed for vaccines and for many of the other behaviors that you'll be studying, but even those can be modified, adding questions that are thought to be useful in a particular context or country. Next, you interview 45 doers and 45 non-doers either over the phone or in person, or for certain populations where you have a lot of people on computers through an online survey as being done in the US right now. With barrier analysis studies of staff and others with higher literacy, respondents can receive a link to fill out an online survey, and we have some examples of those tools if you need them. The first questions identify COVID-19 vaccine acceptors and non-acceptors for interviewing, and the remaining questions are based on 10 different behavioral determinants, up to 12 determinants depending on what you're studying. The results are then tabulated by numerators or project staff, and the tabulated results, that is the number of doers and non-doers, acceptors and non-acceptors, giving each response, are entered into an easy-to-use MS Excel barrier analysis tabulation table. That automatically generates your findings, your p-values, your associations with vaccine acceptance, for example. And then staff use the findings on significant differences between the doers and the non-doers to create useful messages and activities that leverage those enablers and reduce the barriers to the behavior, such as COVID-19 vaccination. And you can then monitor the indicators to track changes in those key determinants. For example, you could monitor what % of people believe that COVID-19 is a serious disease if you find that's an important determinant in your study. Here's an example of the COVID-19 vaccines barrier analysis questionnaire. You'll notice like that first one is open-ended. What do you think the advantages of getting a COVID-19 vaccine would be? And with that, it's very important that you say, what else, so that you get all of the person's responses regarding that, not just the first one. There's a similar question on negative consequences. Sometimes you'll reword the question a bit, depending if it's a doer or non-doer, and that will be indicated in the questionnaire. And then there are closed-ended questions, like this one on social norms, which asked, what portion of the people that you know do you think would get the vaccine? Would you say that most of the people would get it, about half the people would get it, or very few people would get it? So with those, we often include the response categories in the questions so that it's easier to tabulate. Also down here in the bottom corner, you'll see an example of the barrier analysis tabulation table. You'll note that you plug in the number of doers, the number of non-doers, the estimated prevalence of the behavior, and then down below, how many people gave each of those responses. So you only fill out the green cells, and all those other cells calculate automatically. So for example, on the right-hand side, you'll see that one had a p-value of 0.016. Those people who said very few people would get the vaccine in their community. And then it automatically generates that statement that says doers are 1.3 times more likely to give this response than non-doers. That should help you with the analysis, and that some of it is done for you. This table shows, at this point, we have conducted barrier analysis looking at COVID-19 vaccine acceptance in 6 countries, and we're hoping to publish these results soon, and we're eager to find out what you will find in your country. We feel that using barrier analysis gives practitioners a much better idea of what they need to be focusing on in terms of messaging and activities to promote a behavior, especially when compared to just knowledge, attitude, and practice studies or focus groups. For example, here's an example of some beliefs on acceptance of COVID-19 vaccines in Bangladesh, which we completed in December of 2020. Note that this is not barrier analysis type data. This is cross-sectional survey type data. And looking at this, what would you focus on if you only had this data on prevalence of beliefs, or if you heard these responses in a focus group discussion? Well, maybe you should work on those perceptions about negative side effects. A lot of people brought those up when asked what would be the disadvantage of getting a COVID-19 vaccine. Or maybe you could promote more advantages of getting the vaccine other than that it protects you from COVID-19. For example, talking about how children will be able to return to school once enough people are vaccinated, and that people will be able to return to a normal life. Those seem to be on a lot of people's minds and sound like some powerful motivators. And maybe you would not want to work as much on talking about not getting COVID-19 as an advantage of the vaccine, since More than 3/4 of people already believe that. Or focusing on social norms, since more than 2/3 of people already believe that most of their family and friends will get the vaccine. Or maybe you have another favorite determinant or reason or argument for getting the vaccine that you think would be effective. However, of those three checked in green, none were found to be associated with accepting the vaccine. They're most likely not driving the acceptance. And of those rejected, the ones with an X, not getting COVID-19 vaccine was an important driver, and believing that most of my close family and friends will get the vaccine was also highly associated with being an acceptor, that is, being an intended doer. So when we compared acceptors and non-acceptors in a bear analysis study in the more rural areas of Bangladesh, in Thakurgaon district in the Rangpur division, in that study, note that of those three checked elements I just mentioned, none were found to be associated with accepting the vaccine. That is, the proportions of doers and non-doers who said them was about equal, and it wasn't any difference in terms of statistical significance. For example, negative side effects. When we compared acceptors and non-acceptors, those responses were nearly identical. So these things are most likely not driving COVID-19 vaccine acceptance. This is the reason we compare doers and non-doers, to find out which of these beliefs are associated with whatever it is that we're studying, in this case, vaccine acceptance. Instead, here are the things that were most highly associated with intending to get a COVID-19 vaccine in Bangladesh. All of these are statistically significant associations. Social norms were very powerful in Bangladesh. Respondents who believe that most close family and friends will get the vaccine were much more likely to say that they would get a vaccine. Respondents who said that most of their community and religious leaders wanted them to get a vaccine were also much more likely to seek the vaccine, as well as those who believed most people in general will get it. Believing that not getting COVID-19 is an advantage of the vaccine was also a very important driver. Perceived risk was also important. Non-acceptors were 6.8 times more likely to say that they were not concerned at all about getting COVID-19. And perceived access was very important there, as one would expect. Acceptors were 4.8 times more likely to say that they expected the vaccine to be offered within 30 minutes of their home. This is why we want to use bear analysis more for other COVID-19 behaviors. And we believe other agencies should be using this tool in addition to tools like focus group discussions, key informant interviews, and KPC cross-sectional surveys to make decisions around social and behavior change. Many international NGOs are already using barrier analysis, and the tabulation and analysis can be done using a simple spreadsheet, which we've already developed and shared. So this is an easy tool to use. So at this point, we've conducted barrier analysis looking at COVID-19 vaccine acceptance in 6 countries. And we're hoping to publish the results from these soon, so we're eager to find out what you will find in your country. Let's talk about some of those results. Here are some of the most important results from Myanmar. And we also have studies from other countries we'll be sharing. Access there was very important. Acceptors were 5.8 times more likely than non-acceptors to say that they expect the vaccines will be available within 30 minutes of their home. There's a trust problem there. Non-acceptors were almost 5 times more likely than acceptors to say that they trust the COVID-19 vaccines only a little versus a moderate amount or a lot. And the non-acceptors were also twice as likely to say that vaccines were not safe at all. Non-acceptors were more concerned about how long it would take to get the vaccine and more likely to mention chronic or prolonged illness as something that could make it difficult to get a vaccine. Social norms was important in Myanmar as well. Acceptors were 2.6 times more likely to say that they expect most of their close family members and friends to get the vaccine, 3 times more likely to say that most community leaders and religious leaders will want them to get the vaccine, and 3.7 times more likely to say that they would be very likely to get a COVID-19 vaccine if a health worker recommended it. Note that these results can be very country specific. You can find one thing in one country and not find it in another. That's one reason we're recommending that the studies be done in more than one area. World Vision carried out a barrier analysis study in India, in Andhra Pradesh state, Madhya Pradesh, and Assam states of India. And the most important determinants of vaccine acceptance there, non-acceptors were 6.7 times more likely to say that they do not know of any advantages of getting the COVID-19 vaccine, while acceptors were 3.5 times more likely to mention prevention of COVID-19 as an advantage. Non-acceptors were 6.1 times more likely to say that very few people they know will get a COVID-19 vaccine, while acceptors were 2.6 times more likely to say that most people they know would do so. Non-acceptors were 5.1 times more likely to say that lack of information about the COVID-19 vaccine would make it more difficult to take the COVID-19 vaccine. And acceptors were 1.8 times more likely to say that they had not seen or heard anything that would stop them or others from seeking to get a COVID-19 vaccine. Non-acceptors were 5.1 times more likely to say that they don't know or won't say if there are some people or leaders who want people to get a COVID-19 vaccine as a way to either control them or harm them. And there were other important determinants found there as well around perceived negative consequences, access, perceived susceptibility and risk, perceived severity, and perceived divine will. Here's what those results in Tanzania look like. The green bars are the percentages of intended acceptors who gave the response, and again, the red bars represent the percentage of non-acceptors, of non-doers who gave the response. So here, you'll note that social norms, once again, was extremely important in a number of those measures. Trust was very important as well, having trust in the COVID-19 vaccines, and also not whether you're not sure or sure about whether it's safe for you to get a vaccine. Tanzania was one country where we saw that there was a fear of impotence mentioned. When we asked what is a disadvantage, 40% of the non-acceptors said they were afraid that it would cause impotence, where we know that there are no studies that shows that this is the case. So that will be an important thing to message around in that country. Social norms being unlikely to get it if health staff recommend. 93% of the non-doers said, even if a health staff person recommends it, I'm not getting it. That is important because it says we can't be messaging purely through nurses and doctors there. We need to be thinking about other people like religious leaders, maybe community health workers that are a bit closer to them, and other leaders, other people. Perceived severity, the acceptors were more likely to say yes, COVID-19, it would be very serious if someone in my household or if I got COVID-19. And perceived divine will was found to be important. 60% of the doers said God or Allah approves of COVID-19 vaccine, where only 33% of those non-doers and non-acceptors said that. These are the most important things that we found in Tanzania. And these are some of the selected associations in Kenya. And you'll notice there's some overlap here and some things that are different. Non-acceptors in Kenya were 6.8 times more likely to say they have no trust at all in a COVID-19 vaccine, 4 times more likely to say it wouldn't be safe at all for them to get it. Non-acceptors were also much more likely to say that most close families and friends will not get a COVID-19 vaccine. The acceptors were more likely to say that their community and religious leaders will want them to get a COVID-19 vaccine. So it'd be important to use community and religious leaders there to message on this. Acceptors were more likely to say that they're very likely to get a COVID-19 vaccine if a health worker recommends. So there, we do know that, you know, if acceptors are more likely to listen to these health workers. Acceptors were 2.2 times more likely to say they'd be very serious if someone in their household got COVID-19. So we need to make sure that everyone understands how serious a disease it is there. And some of the other important determinants we found were like positive consequences or advantages, perceived divine will, perceived access, perceived self-efficacy, and perceived action efficacy. Now, I've done some studies. For example, I remember studying, I think it was hand washing in Mozambique. We only found like 1 or 2 important findings, especially just unavailability of soap. When that happens, it's good. It basically means maybe you can have your strategy center on only one type of message or activity, or 2 or 3, and you can really change that behavior. This is going to be a lot more difficult to change because there's a myriad of reasons why people who aren't wanting to get the vaccine are not getting it. It's social norms. It's how you think about the disease. It's whether you trust the vaccine or not. This means that we're going to have a very robust information campaign to be able to do something about this. So, and if we have data on 6 countries, well, why do we need to do more barrier analysis studies? And the main reason is that these determinants vary by country and context. You can't assume that you'll find the same determinants where you work, so we need more data. For example, these 2 lists show the top determinants in 2 different countries in Asia. And note that there are 2 that are common to both, perceived social norms and access. But the others depend on the country where we did this study. And I would expect we could very well find different results by region of a country as well. We will eventually pull these studies into a compendium once we have all of the data in, similar to what we did with the Ebola-related barrier analysis studies during that outbreak. And for those of you planning to do new barrier analysis studies on COVID-19 vaccine acceptance, for example, in West Africa, we're hoping to include your barrier analysis studies in that compendium. We also hope that our child protection staff will create a compendium of the barrier analysis studies that they do on child marriage and child labor. This table shows which determinants of COVID-19 vaccine acceptance were found to be important in the 6 barrier analysis studies that have been completed so far, and which were more strongly correlated with vaccine acceptance. And you'll note that 1 check means it's still an estimated relative risk of 4, meaning those statements saying like you're 4 times more likely to give this response than a non-doer. The 2 checks is a higher association with an estimated relative risk of 4 to 8, and the 3 checks means over 8, 8 or greater. And this shows that level association between the determinants and the vaccine acceptance. So you'll see in some countries, some determinants were stronger than others. There's some where we didn't find an association, where we have the red X's, where those determinants were not found to be important in terms of driving it. So how is World Vision using this information from these barrier analysis studies? There are multiple ways. We're using them to inform stakeholders and policy through presentations and thought leadership. For example, Dr. Robert Kanwagi, who was appointed after a competitive selection process to the COVAX facility demand working group, has used this as he presents and leads meetings with them regularly. Robert and I have also presented on them to the UNICEF-led Africa and South and Southeast Asia COVID-19 Demand Task Force. Dan Irvine on my team, Robert and I have presented on them to the Vaccine Confidence Project, which is a leading think tank on vaccine hesitancy in the world. We were also successful in getting UNICEF to include barrier analysis in the African version of the Data for Action Manual and requested that WHO do likewise at a global level. Robert was asked by the WHO to coordinate the review of all of the African national deployment and vaccination plans, so he has been able to use this data and advocate for more barrier analysis studies through that role. And our communications staff have put out numerous press releases and thought leadership pieces using some of these barrier analysis results. We're also in the process, as I mentioned, of publishing this evidence. We'll be submitting a summary of the 6 COVID-19 vaccine barrier analysis studies to a peer-reviewed journal. Adunia Kebede and the TSO is leading on that work, and a few of us are co-authors as well. And Robert Konwagi and I will be co-authoring another partner's barrier analysis study on the DACA barrier analysis study as well with Abu Kalam. You may be asking yourself, what do you do with all this data once you have it? By knowing what determinants and specific responses are important, you can use that to develop both activities and messages to confront each barrier and leverage each enabler. Here are a few of examples of what can be done for 3 of them. For example, for perceived social norms, if you found that that is an important determinant, that they're either there's a big difference between doers and non-doers for that determinant, you can make invisible behaviors like acceptance visible by getting people to put stickers on their homes or to use a lapel pin so people can see that they are planning to get the COVID-19 vaccine. That is, they'll begin to see that maybe the majority of people around them plan to get vaccinated when they didn't know that before. If perceived access is a problem, you can start getting the word out about where the vaccine will be accessible and advocating for the Ministry of Health to make it as accessible as possible to people, possibly doing more outreach posts, for example. If perceived consequences, the advantages of getting the vaccine are found to be important, you can do things like gathering testimonials from people who plan to get the vaccine or using essay contests. I included links here which provide more information on a few of these social behavior change activities, linking to some presentations I did on the past on persuasion. For perceived risk or susceptibility, you can work with the news media to be able to disseminate stories of people who have died or had serious cases of COVID-19, leveraging the availability heuristic. And that's where people that have heard stories that they can remember of people having a problem are more likely to think that that problem is common. And for perceived divine will, you can work with faith leaders to help them create sermon guides or feature faith leaders who support vaccination and radio spots. And you should definitely be using our forthcoming Channels of Hope COVID-19 vaccine module. Here are some links for more information that we encourage you to look at following this training. We have the World Vision Vaccine Capacity Statement that I mentioned early on. We have our main guidance on promoting COVID-19 vaccines through World Vision field offices. As I mentioned, both the Channels of Hope module and the CVA tools are being developed that they're modified versions to help they're basically for use during COVID-19 vaccine promotion. We have all of these result summaries and tabulation tables from the countries where we've done barrier analysis so far that you can access on StoryHub. We have the barrier analysis tools for COVID-19 vaccines already developed, like the barrier analysis training manual written by Bonnie Kittle, which I was a reviewer of that. The COBO questionnaire for COVID-19 vaccines, so you can take that and use as is or make some small modifications. We also have a Microsoft version questionnaire, a paper questionnaire, if you don't plan to use COBO. We have a barrier analysis tabulation table that's set up for the COVID-19 vaccines, and also one that's set up for any, it's more generic and can be used for any behavior, along with some tabulation instructions that will be covered during this workshop anyway. And the barrier analysis questionnaire to assess religious leaders' promotion of COVID-19 vaccines. That has already been developed, and if you choose to study that behavior, whether religious leaders want to promote or planning to promote or are promoting COVID-19 vaccines in their congregations or not, we do also have a COBO and an MS Word paper questionnaire version of that as well. I hope this was a very useful workshop for you if you're just ending it, and that you'll be able to use these tools going forward, not just for COVID-19 vaccines or the behavior you might be studying right now, but the hundreds of different behaviors that this can be used for. Thank you very much.